take any questions you guys have. She'll be there because I can't see your questions. I'm here, so if you have any questions, feel free. We have Dr. Estrevera here.
Hi, everyone.
She's a new vascular surgeon in Naples, Florida. Figured, we did a good presentation at the diabetic conference not that long ago, a joint conference, and very positive feedback. So figured we have you join us on Facebook Live, and we'll talk about peripheral arterial disease and as far as also saving limbs and how vascular surgeons and podiatric surgeons work together to keep your limbs on you. So as we know, once you start losing a toe, then you start losing a foot, start losing an ankle, leg, and then after that, losing your life. I think the statistic shows, I think the 5-year mortality rate is pretty high, right, for amputations?
Absolutely.
So I think as teamwork, I think you guys have done a lot more toward endovascular intervention now, right? Versus open.
Absolutely. So endovascular intervention is where we're able to take pictures through accessing the artery, and we use catheters and wires similar to what they do within the heart to open up blockages within the arteries. I brought a stent with me today just to kind of show you guys. Once we open up a blockage in the artery, at some point, if it's completely occluded, they'll need a stent placed. And this is a stent. You can see, I'm not sure how well you can see it. It's a matrix and almost a woven cylinder that's made out of nitinol. And that's what we place inside the arteries sometimes. There's a couple different types of stents. Just a plain stent like this would be called a bare metal stent, and other types of stents actually have a drug that's impregnated within them that stops hyperplasia or the stent from becoming re-occluded at a lesser rate.
So this is pretty cool. Would this be the size of a artery above the knee, you would say?
Yes, so that could be the appropriate size stent for either the popliteal artery, which is the artery, it starts just above the knee and continues just to below the knee. So that would be about the right size. And then also in female patients that have much smaller vessels, this would be the size of the superficial femoral artery, which is within the thigh.
Now, all this, the map right here that Dr. Estrevera brought with her right here, this all goes down to the foot, just as the nerve does. The nerve travels usually on side of the vein and artery, all the way down. Sometimes patient asks us, what does vascular surgery have to do with my toes? Well, now you see, it flows down. As far as the artery is concerned. So that's why it's great to work with a vascular surgeon. They're able to stick one of these stents in there to open up the flow, sort of opening up the plumbing. A lot of times, if we don't have water, we cannot heal, right? So sometimes before surgery, if we can't feel a pulse in the foot, we send our patient to the vascular surgeon, and they go ahead, either they put in these stents, which is great, by the way, because when I was in residency, this was just coming out. The interventional cardiologist. I think this came from their field, right? Is that where it started?
Yes, that's where the concept came from and was expanded into other places within the body. And today we fix not only blocked arteries with stents, we also fix veins that are collapsed, as well as aneurysms. And aneurysms that we fix with stents, there's a actual fabric covering over that stent that allow us to fix aneurysms or enlargement in blood vessels just through small access in your groin.
Yeah, this is huge because I remember in residency when this was just coming in, a bypass was standard. That's all we had. We didn't have any flow. We're calling a vascular surgeon. Vascular surgeon makes this big, huge incision. Either use the vein graft. You guys use vein grafts as well as artificial graft. But that was a big incision. How long does that take to heal?
So again, it depends on what the extent is of your disease as far as how it takes to heal. So depending on if you have vein that is big enough meaning a size-wise of the vein itself, which allows us to use the vein for a bypass. So what we know from following patients after bypass surgery is if the vein is smaller than 3 millimeters, that those vein grafts don't stay open and have very poor patency. And so in those patients, we use a conduit, and this is a conduit. This is what we would use for a bypass, and this is made out of PTFE. It's almost like a styrofoam cup tube. And so unlike Dr. Lamb, we could bypass him from up here. Let's say he's got his aorta and his belly is occluded. We could bypass him from up here to his axillary artery to his femoral artery and get him blood flow down his leg. So vascular surgeons, we're basically human plumbers.
This looks like a very expensive straw looking at this, right? But this literally can save your leg and save your life. Vascular surgery and working with podiatry, we control the infection. And when we do our amputation, believe it or not, people thinking amputation, how is that saving? Well, we're saving because when we amputate at a certain level, we take away the disease tissue, the infected tissue, so it doesn't spread, the infection doesn't spread. That's called source control. So between vascular surgeons doing their stent, doing their bypass with artificial means, or if you have veins still available, we're able to save diabetic limbs, or even you don't have to be diabetic. Smokers, right? Smokers, we see that smokers, diabetic and smokers, even worse.
I think the key to working together with both a podiatrist and a vascular surgeon is the fact that the podiatrist is a second set of eyes to the vascular surgeon, and we are vice versa to them. Through insurance and Medicare coverage, you can come and see a podiatrist on a regular basis and have somebody check your feet. And that's something that as a vascular surgeon is something that isn't necessarily covered unless you have a new indication to see a vascular surgeon or a certain disease state that requires a follow-up. The other thing is amputation is not really the end of the world. It's a scary word, and I'm sure it's a horrible thing when you have to hear it about yourself that you're going to require an amputation. And I will tell you that a leg amputation to a vascular surgeon is like a funeral for us. We strive very hard to prevent any type of amputation and do all we can. And early intervention is really the key. There's a number of very, very neat, I don't know if neat's the exact word, very creative, I'll say, amputations that podiatrists are able to do, allowing you to still have your mobility and not require something like a below-the-knee amputation where you no longer have your foot. So it's just also something to think about, that if you have a wound on your foot and you're putting off seeing somebody, that the sooner you have it treated and the sooner you have some type of an intervention performed, it can be life and limb saving.
It's funny you say that, because I often tell my patients, when they see us, our goal is to keep your toes. Our goal is to keep your foot. Without your toes, without anything further from your ankle, we lose our business. So, right? So if you think of it that way, our incentive is to keep as much as we can. But really from a health standpoint, right? Below knee amputation, doesn't that increase the cardiac load on the patient?
Yes, absolutely. So when you have a below the knee amputation and also an above the knee amputation, it increases the amount of workload on your heart in order to walk with a prosthetic. A lot of patients that have disease in their legs and their arteries that require an amputation usually have disease in their coronary arteries or arteries in your heart. And unfortunately, when you have disease in one of your arteries, it's usually somewhere else as well. And so if your heart is weakened or deconditioned, having an amputation is always a possibility that it could make you immobile. And that's something that we don't ever want to take away from somebody, is their ability to ambulate and to be mobile and to maintain your quality of life.
Well, no, as they say at Temple where I graduated, motion is life, and another thing, when you're bedridden, you get not only the Hilti cubes that are really difficult to heal, the cube in the sacrum too.
Absolutely.
And it's all downhill at that point. So we definitely want to keep our patients mobile. I think working as a team is great to be able to we see our patients, as Dr. Echeverria said, at podiatry, we can see you every 6 months, every 9 weeks, depending on your risk factors. So a lot of times, they'll get referrals from us because we see them first. We identify the peripheral arterial disease, and sometimes we're the first to diagnose diabetes too from the feet.
Yeah, absolutely.
From peripheral arterial disease to neuropathy. So I think is absolutely very important. And sometimes I think the primary care sector, sometimes they forget about the referral sometimes. But definitely, if you have numbness in your toes, your toes are turning blue, you have an ulcer, or you don't have any of those, but you're just diabetic, you haven't seen a podiatrist, you really should see a podiatrist. We could point out things for you, we could check for neuropathy, and if you have to, we could send you to the vascular surgeon, and if we catch the disease early, you get a stent. At the very worst, those bypasses can be pretty invasive, no? I mean, the
yes,
incision's
it's
pretty
an
big.
inpatient procedure that's under a general anesthetic, so that puts you at risk of heart attack and stroke. Whereas a stent or an angioplasty, endovascular interventions, it's done in an outpatient setting just with sedation, and you go home the same day, a few hours after the procedure. And it's all in all some great technology that allows patients to get back to their life a lot quicker.
It's pretty amazing. You guys have these lasers nowadays, right? that breaks away the calcium deposits in the leg. I've seen that demonstrated. How's that working out in the office setting?
So there's a couple different types of pieces of equipment that are somewhat the same as the laser. And they're called atherectomy devices. And what they do is they break up plaque and calcium and increase the luminal size of the vessel to allow us to fully expand it back to its normal size. So there's a laser that can be used. There's different types of what we call directional and rotational atherectomy. And I explain it to my patients as it's a human Roto-Rooter. And that's more or less what it does, is it breaks up the plaque just like Mr. Roto-Rooter would break up the clog in your drain, bringing you better blood flow all the way down to the tips of those toes.
For the podiatric medical students out there, the residents out there that are watching, or even podiatric fellows that are watching, when you guys do your intervention, endovascular intervention, what is the ideal time, would you say, for us to go and intervene and do our amputations, source control, or taking away the dead tissue? When do you think is a great time for us to go in?
So in my opinion, a lot of it depends on the logistics of where you are, and if you have somebody that can help you out in an expeditious fashion. As an example, he'll call me up and say, hey, I have this patient, he's got a wound, he really needs surgery, I've started him on antibiotics, can you take care of him this week? And I say, yes, send him over right away, and I take care of him as soon as possible. So in that type of case, we are going to get you better blood flow before you create the wound in a patient that is not systemically ill. And in that case, I think that works great to revascularize first. In a hospital where you have wet gangrene or something to that effect, where the patient is systemically ill, I think it's important for source control right away and then revascularization afterwards, because oftentimes in those patients, they're going to need a revision type of surgery anyways. So source control first, leaving an amputation site open or whatever you've debrided, having a revascularization, and then coming back for a revision or a definitive operation.
Cool. So we're talking about two different scenarios here, right? We're talking about one where coming with a wet gangrene is the infectious emergency where we want source control first to worry about circulation later, because we have to get rid of the infection first. Mm-hmm. Versus the other one, they're stable, dry gangrene, and you guys would do your intervention, and because it's not a infectious emergency, And then we come in and do our reconstruction, whereas we take away the dead tissue, so that way it's not ending up being a source of infection, and then we could close them up so they could wear prosthesis better.
Exactly.
You know, that pretty much sums it up. Let's say a person comes in, you know, I know residents sometimes, residents and podiatric medical students, they're even attendings when you're out, they're thinking, if they have this person, in this case scenario, a patient has dry gangrene of the toes, and they really need a transmetatarsal amputation. Let's say you go in and do an intervention, put a stent in there, and now we have bounding pulses. Great. Let's say you do it. You do this on Monday. You do intervention on a Monday. Tuesday, Wednesday. When would you say is a good day for us to go in to do our amputation? Immediately.
Anytime after Monday.
Anytime after Monday. 24 hours, you say, is a good idea.
I think that's sufficient time, as long as you're okay with the patient being on aspirin and Plavix without them stopping that, because that ensures and improves the patency of our intervention. So as long as you're not stopping that, anytime.
Yeah, no, actually, you know, that's another topic too, you know, the aspirin, the Plavix, and the Coumadin. A lot of time anesthesia gets all freaked out when they see patients on that. We're like, no, it's okay. I think we can handle that, because, you know, when we go in there, we see a bounding pulse there. We actually like that.
Yeah, we love blood flow.
We love blood flow. We tie them off, right?
Exactly.
Tie them off in the foot when we do amputation, so we get flow to a flap on the bottom of the foot.
Exactly. You know, as far as blood, you know, vascular surgery goes, either it's bleeding or it's clotted. There's really only the two options. So, but we like bleeding, that's for sure. We can handle that any day.
Well, we believe it or not, we like that too, because if a person is bleeding, that means they're going to heal for us, right?
Exactly.
You know, and another thing too, you know, if you don't have blood flow, your antibiotics are not going to get to where you need it in the foot and the ankle.
Very true. Very true.
You know, sometimes you can have antibiotic till a cow comes home, but it's not getting there, because how does it get there? Blood. It's not in your blood. Your blood's not getting there. You're not getting your antibiotics. So again, you know, it's very important. You know, from a podiatric standpoint too, on our end, you know, there's a lot more that we do as far as, you know, offloading, you know, special shoes, special insoles to take the pressure off the area, so you don't end up with an ulcer, you know. So what we do beforehand, but when you go past that step, that's when we step in together and we work as a team, from vascular surgeon to podiatric surgeons. I think it definitely makes a great team to save the limbs and save lives of patients.
Could you comment a little bit on some of the foot deformities that you see in diabetic patients, and maybe some of our viewers out there, things that they might see on their feet that should make them have some heightened awareness to come in and see a podiatrist and seek some care?
Yeah, you know, a good indication, if you don't have hair on your feet, your toes, that could be an indication, not always, but it could be an indication of peripheral arterial disease.
Definitely, and we see that too, as far as on the legs, is that if you don't have hair on your legs, a lot of times that is an indication of poor arterial blood flow.
And, you know, thick, ugly nails, you know, a lot of time, you know, sometime in the doctor's lounge, you know, I'll get the OBGYNs going, hey, joking about us clipping toenails, but you know what, that toenail clipping is very important, because these thick, infected nails full of fungus can be so thick they can cause an ulcer in the toe. They can end up losing toes and feet. So that's why, you know, Medicare actually pays for us to cut your nails every 9 weeks, because as they get more infected, they get thicker, they can actually cause an ulcer. So that's another thing that they should look for. And something as mundane as a callus, you know, we don't, you know, you have a callus in your foot, you don't run to me for that. But if you're diabetic, you know, you have a callus. What does that mean? It means that you have excessive pressure on your feet. And diabetics, you know, you're more prone to something called Charcot. If you have neuropathy, which means you don't have sensation about your foot, neuropathy, that can actually cause ulcer, that can cause your foot to collapse via something called Charcot arthropathy. You know, you can notice your foot collapsing, your foot getting swollen and collapse. So there's a lot of different warning signs that, you know, if you're not diabetic, not neuropathic, you don't really care about. But you know, we talk about thick, ugly nails. We're talking about no hair on your legs, and we check the feet and the legs. But you know, if you don't have it in the legs or the toes, that's an indication you may have peripheral arterial disease. And, we can check for it really easily, The peripheral arterial, we do a quick screening. Obviously, number one is our hands. We feel for the pulses. But what if we can't feel it? What are the stuff that we can do?
So there's a lot of minimally invasive testing options as far as what we can do to test your blood flow to your feet that can be done right in the office. One is checking what's called your ABI, or your ankle brachial index. And this is performed by placing a number of blood pressure cuffs, one on your arm and then also throughout your leg, and looking at the ratio of the blood pressure between the brachial artery and the arteries in your legs. And this gives us some information. In diabetics, ankle brachial indexes are oftentimes falsely elevated because the vessels are more diseased. And in this case, definitely if there's any type of abnormality or non-healing wound or any type of cyanosis or blue color on the bottom of the feet or the toes, it's important to seek some type of evaluation from a vascular surgeon to evaluate what's going on with maybe some other tests.
Oftentimes I get my ABIs come back from radiologists, and I'll see some outrageous number. Now, normal, as a background, normal is ratio of 1.0. So which means that the pressure in your arm and the pressure in your ankle is the same. So you get 1. If you have calcinosis or hardening of the vessel in the ankle, you'll typically have a higher number, like a 1.5, 1.6. Now, a question that the medical students may have is, what happened if they come back with, 1.6? Does that mean they have excellent blood flow?
No, it doesn't. And I have patients that say that to me. Well, I got the report from my doctor and it says here anything above 1 is normal. How are you telling me that this isn't normal, doctor? I say, well, you have this big wound on your foot that's been there for 4 months and isn't healing. And you have no pulses that I'm able to feel. And we need to look a little bit further as to the cause of what's going on.
Yeah, just because the higher the number doesn't mean you're, as one of my attendings you say, more better. The higher number does not mean that. So definitely it's a good baseline test.
It is.
We could screen out a lot of patients, but that's not end all be all. So that's why you need doctors, you need the cardiac physician working with the vascular surgeon. If, like you said, if there's a wound that's not healing, there's obviously something wrong, right? It's either infectious or vascular. Those are really the two main things why they're not healing. Pressure is another factor too. If you're constantly walking and you have the submetatarsal 1 ulcer on the bottom of your foot, gosh, we need to figure out why you're having that. Maybe we can offload it. So I think that's why teamwork helps,
Yeah, absolutely. And that's something that sometimes we'll see a patient first and I'll say, well, like, who cuts your toenails or who takes care of your feet? And they'll say, oh, well, I go to so-and-so nail spa and they cut my calluses and cut my toenails. And it's almost like nails on a chalkboard when I hear that, because a lot of times when you go for a pedicure, those are not people that are trained to cut nails in patients that have diabetes and neuropathy. And sometimes they're cut a little bit too square and they dig into the feet, the toe next to them, or, it's just not cut short enough and alters the way the patient walks and the shoes that they wear. And it can kind of be a slippery slope going downwards. Not to say that if you have diabetes, you cannot go get a pedicure, but you need to have somebody that's trained to cut toenails in a diabetic patient and care for your feet. Do that. And also when you go to those pedicure and spa type places, it's important not to allow them to cut off your calluses and shave them. One thing is if you aren't sure of what your vascular status is in your feet, any wound that is made may not have the blood flow to heal. So you want to be conscientious about that.
Well, definitely. I doubt your neighborhood pedicurist knows where the DP artery and the PT artery or where to feel for them, or if you have them, right? So sometimes I'll get patients come in and say, oh, yeah, my pedicurist is afraid to cut my nails because they're so thick or my toes are blue. Well, sometimes we'll hear that. That's great. but most of the time they're not medically trained. Again, I'm not saying don't go get a pedicure. You know, my mother actually, when she retired from her normal job, she couldn't stay home, so she actually ended up getting a cosmetology license to do nails. So I'm not saying don't do it, but always don't depend on that. Always get it checked. Follow your podiatrist. Make sure if you're a diabetic, you definitely need to have a podiatrist, like you need an ophthalmologist. Exactly. And sometimes you need a vascular surgeon. So good. You know, I think we covered a lot. Are there any questions out there, Christine? No, not yet. Okay. So it's our first Facebook Live with another specialist this time. So I think any questions, feel free. We may have Dr. Echeverria come back and answer those questions next time as it goes.
All right, fantastic. Keep treating that diabetes and controlling your blood sugars, and see your podiatrist and get your nails evaluated and your feet. And they'll send you to any referral physicians that they think are in your best interest.
Yeah, we work to save your feet, save your limbs, and you know, once you get amputation, it's downward spiral. So we try to avoid that. So that's one way to cut down the mortality rate. So thank you everyone for joining us, and thank you Echeverria for joining us today.
Thank you for having me.
No, thank you taking time out of your busy schedule.
Absolutely, my pleasure.
Thank you. Have a great one.
You too.